Hello, future nurses, and welcome to this week's lecture. Today's topic is an absolute cornerstone in nursing, understanding fluids and electrolytes. This knowledge is not just crucial for your exams, but is key to your everyday clinical practice. So, let's get started and demystify fluids and electrolytes. Every cell in our body relies on a precise balance of fluid and electrolytes to function properly. Today, we're going to break down this complex topic into simple, easy to understand concepts. Our bodies have two main fluid compartments, intracellular and extracellular. Intracellular fluid is inside the cells, and extracellular fluid is outside, including your blood. One of the essential homeostatic functions of the body is to maintain fluid and electrolyte balance within the cells and their surrounding environment. So, a key thing to remember is that cell membranes are selectively permeable, meaning that water can move freely throughout the cell membrane, while other substances, such as electrolytes, require special transport proteins, channels, and often energy. So, what are electrolytes? They are minerals such as potassium, calcium, magnesium, phosphate, sodium, chloride that circulate in your blood, stool, urine, stomach juices, and body tissues. And once they are dissolved in water, create electrical charge, which means that these electrolytes play a critical role in everything from nerve transmission to muscle contraction. Therefore, whenever we have these imbalances of these electrolytes, we're going to start seeing certain abnormalities in these processes, depending on if it's high or low. For example, with muscle contraction, in certain electrolyte imbalances, you can start to see muscle spasms. So, as an example, what is a very important muscle in our body? That's right, your heart. So, you can start to see abnormal ECG findings with certain electrolytes. And as we go through this lecture, I will highlight that for you. But for now, let's talk about how electrolytes are maintained in our body and how do we keep them from being too low or too high. We mainly get electrolytes from our food. Whenever we eat and drink, it goes into our body and is absorbed in our gut. So if you have a gut problem, let's say an issue with the small intestine, it can affect how you are absorbing certain electrolytes. Then it enters into your blood, and your blood is filtered by your kidneys. So just remember, if you have any kidney problems, you're probably going to have electrolyte problems too. But we will discuss the kidneys and how they work and impact your electrolytes next week. Other ways our electrolytes can be affected is that if we have an exit route for them. And this could be anything from trauma or where they have a lot of blood loss, or big things like burns, or the patient could just be really sick and throwing up or having diarrhea. Maybe they have NG suction and we're sucking off too much of those gastric juices, which are really rich in many of our electrolytes. Or maybe the patient has some sort of disease process that, again, we will be discussing further throughout this semester. Now, let's look at these electrolytes individually. I want to start with sodium. So, sodium is a really important electrolyte which plays a huge role in regulating the water inside and outside of our cell, along with muscle contraction and nerve impulses. So, if you get an imbalance of this electrolyte, you're going to start seeing issues with these processes. A normal sodium level is about 135 to 145 milliequivalents per liter. So anything less than 135 is considered hyponatremia, and anything greater than 145 is considered hypernatremia. So now I want you to see a visualization of how sodium really works in that extracellular area and how it affects the cell. Here we have hypernatremia conditions. So in the blood, there is a lot of sodium hanging out. And you want to remember that water follows sodium. So where there's a higher concentration of sodium, that's going to pull the water from where it is to that higher level of the sodium. So if there is a high extracellular sodium, the water is going to follow that sodium and it's going to leave the intracellular area, causing that cell to shrink and shrivel up. Now, on the flip side, hyponatremia is when we don't have a lot of sodium in that extracellular area. And again, water follows sodium, so it's going to leave that extracellular area, follow the sodium into the cell and cause that cell to swell and get really big and poofy. So what happens if you have too much sodium, or hypernatremic? Remember the mnemonic fried or salt. So F is for fever, low grade, or flushed skin. R is for restless. I is for increased blood pressure. E is for edema, which will typically be peripheral and pitting. D is for decreased urinary output or dry mouth. And then the mnemonic salt is pretty similar to the mnemonic fried. So S is for skin flushed, A is for agitation, L is for low grade fever, and T is for thirst. Now, late and serious signs of hypernatremia, and this is a big tip for the NCLEX, is a swollen, dry tongue, nausea and vomiting, and increased muscle tone. Now, these are very late signs of a very severe hypernatremia, but the NCLEX does like to ask those types of questions, and so just write those down and remember those as a good tip. For hyponatremia, which is too little serum sodium, remember the mnemonic low sodium for the signs and symptoms. L is for level of consciousness, which will be altered. This could be a little bit or a lot, but there will be some alteration. O is for orthostatic hypotension. So kind of the opposite of hypernatremia, where the blood pressure is high, the blood pressure is low with hyponatremia. W is for weak muscles, which can be as profound as them being flaccid. S is for seizures. Now, this is a huge risk of hyponatremia, so write that down. D is for diarrhea. I is for increased intracranial pressure. Because remember, guys, when there isn't a lot of extracellular sodium, the water follows sodium and then it swells those cells. So you have this increased pressure in the brain. U is for urine osmolality high. So this would be if they're urinating out more of their sodium from certain conditions like diabetes insipidus. And M is for more bowel sounds, because you know that diarrhea is going to get things moving. Now let's look at the electrolyte chloride. I wanted to do chloride after sodium because these two electrolytes really go together. Generally, if there's a loss of sodium, there's also going to be a loss of chloride. And you're going to see a lot of overlapping causes and signs and symptoms. Chloride is very important for helping to maintain our acid-base balance because of its relationship with bicarb. It also plays a role in digestion because we need it in order to make hydrochloric acid. And it has a role in balancing the fluids in our body with the help of sodium. A normal level is 95 to 105 milliequivalents per liter. The chloride levels are maintained with the help of our kidneys. They tweak our blood and decide how much chloride we need. If we don't need a lot, we're going to excrete it. It also is excreted through the sweat and the GI juices. So if you have some issues with the kidneys, or you're sweating too much, or your GI juices are kind of messed up, then the chances are you'll likely have an imbalance of your chloride levels. The signs and symptoms of hypo and hyperchloremia don't have their own specific ones compared to other electrolytes. The symptoms are typically going to be associated with whatever is causing the problem, and if you can really remember the signs and symptoms of hypo and hypernatremia, you can remember what hypo and hypercholemia is going to be, because they really do overlap. Now let's look at the electrolyte potassium. So potassium has an opposite relationship with sodium compared to how chloride had a similar one. So chances are, if you have a high sodium level, you're going to have a low potassium level. And if you have a high potassium level, you're going to have a low sodium. And this is because potassium is mainly found inside our cell, whereas there's a higher concentration of sodium outside the cells. So they work together to help balance the fluid within and outside of the cells. Plus, they play a huge role together with the sodium and potassium pumps. Now, the role of potassium is big with muscle contraction and nerve impulses. So if you have an imbalance of this electrolyte, you're going to start seeing issues with this. A normal potassium is about 3.5 to 5 milliequivalents per liter. So as you can see, it's a very narrow range, but it's a very important electrolyte. So let's look at what causes hypokalemia, so low potassium in the blood. One of the main causes of hypokalemia is loop diuretics, like furosemide, which causes your kidneys to waste the potassium. So that's a big thing to monitor on a patient on loop diuretics, is their potassium levels. Corticosteroids can also cause hypokalemia, and if a patient has too much insulin, and the reason for this is because insulin makes potassium move inside the cell. So we're causing it to leave the blood and go inside the cell, which is then causing a drop in the blood levels. Cushing's syndrome, due to high cortisol, which decreases the potassium and increases the sodium. Starvation, patients who have been under extreme conditions where they haven't been able to eat can cause hypokalemia, or losing too much potassium. And this is again from GI juices, which is, potassium is richly found in those GI juices. So patients that are vomiting, or if they have GI suctioning through an NG tube, those are things that can cause that hypokalemia or potassium to be low. So what are the signs and symptoms that you may see in a patient with hypokalemia? When we have low potassium levels in our blood, remember that everything is going to be low and slow. So remember the 7 L's. The first L is that a patient is going to be very lethargic and they can be confused. Second L is for low, shallow respirations. Third L is for lethal cardiac dysrhythmias. They may have ST depression or shallow T waves or even a projecting U wave. The fourth L is lots of urine. They can have frequent urination where the kidneys are just unable to concentrate the urine. The fifth L is leg cramps. The sixth L is limp muscles, and they may have a decreased deep tendon reflexes as well. And then our last L is for low blood pressure and heart rate. Now, what can cause hyperkalemia, where we have too much potassium in our blood? Well, anything that really causes the potassium in the cell to move outside of the cell into the blood is going to raise those blood levels. So if a patient has severe burns, this can occur along with tissue damage, such as a condition called rhabdomyolysis. This is where you have the breakdown of muscle tissue. So whenever that muscle tissue is breaking down, it's leaking potassium into the blood. Addison's disease can also cause hyperkalemia, and this is where we have decreased aldosterone. So we're going to be excreting our sodium, but increasing our potassium. Renal failure in patients who have elevated BUN and creatinine, you're going to definitely see that potassium level increase very high. And many times they need dialysis to bring it back down. And medications can do this as well, such as potassium-sparing diuretics like spironolactone, ACE inhibitors, or even NSAIDs. Now, what are the signs and symptoms of hyperkalemia? Well, to help us remember the symptoms, use the mnemonic MURDER, because if the potassium levels get too high, in the end, it's going to murder the patient. So, M is for muscle weakness, U is for urinary output, which is going to be very little, and this is very common in patients who have renal failure. They'll be putting out very little to no urine at all. R is for respiratory failure, because when the levels get so high, those muscles, they'll just quit working, and then it makes it difficult or impossible for them to breathe because that diaphragm is just not working. And then D is for decreased cardiac contractility, because again, it goes to those muscles not wanting to work as well. So these patients are going to have a weak pulse or a very low heart rate. And then E is for early. And you're probably going to see some early muscle twitches or even some cramping. R is for rhythm changes. And I would remember this, that they are going to have very tall peaked T waves, and you can also see prolonged PR intervals as well. Now let's talk about the electrolyte calcium. This is an essential ion that plays a huge role in the health of our bones and our teeth, along with muscle and nerve conduction and clotting. In order to maintain a good level of calcium, we have to have a diet that's rich in calcium. Our gut plays a huge role with us absorbing calcium, and once we absorb it, what we don't need to maintain that good blood level is going to be stored in our bones. Now, our bones will monitor our blood levels, and if those levels are too low, like in hypocalcemia, the bones will actually start to release the calcium back into the blood. But if this keeps happening over and over, it's going to make the bones really weak over time, and the person can have osteoporosis, which will increase their risk of bone fractures. Calcium is regulated by 3 different things. One is vitamin D. It's very important the person has vitamin D on board in order to absorb calcium. Second, the parathyroid hormone, or PTH. And third, calcitonin. PTH is produced by the parathyroid gland, and calcitonin is produced by the thyroid gland. So, if you have destruction to these glands, or maybe a patient's had surgery, we can alter their calcium levels. A normal calcium level is 8.5 to 10.5 milligrams per deciliter. So, let's talk about what happens whenever we get a really low level of calcium. We start to experience hypocalcemia. Let's discuss the different things that cause hypocalcemia. The first thing is a decrease in the parathyroid hormone. Typically, this is going to happen with patients who have had surgery of this structure, especially in things like thyroidectomies. Second is from a decreased intake of calcium. For some people, this is a very hard thing to keep their calcium levels maintained, especially if they have lactose intolerance. So they'll have to be very conscious about making sure they get enough calcium through other sources. Having a low vitamin D level can cause this as well, because vitamin D plays a role with absorbing calcium. Chronic kidney disease, because the kidneys are wasting too much calcium. Biphosphonates can cause this as well. Now, these are a medication drug class that's actually used to help treat osteoporosis, to make the bones stronger. And it does this by telling the body and telling the bones to hold on to that calcium. But as we discussed earlier, the calcium is constantly reading the blood to see how much calcium is in there and if it needs to release more calcium into the bloodstream. The biphosphonates telling the bones, no, you don't give up your calcium, makes it so our serum blood calcium levels can drop down and be low. Another drug group of medications include the aminoglycosides. Now, these are antibiotics that end in mycin, and they can cause the body to waste calcium through the kidneys, making you pee out more calcium. And then there's some anticonvulsants like phenobarbital. Now, what are the signs and symptoms of hypocalcemia? We know that our muscle and our nerves are definitely going to be affected. So let's remember the word cramps. C is for convulsions. R is for reflexes hyperactive. When you check those deep tendon reflexes, they're going to be very hyper-reflexive. A is for arrhythmias, and they will have prolonged QT interval if the calcium is severely low enough. M is for muscle spasms in the calves or the feet. This is known as tetany. P is for positive signs, and these are signs that you can see in a patient who have a really low calcium level. One of these signs that you want to remember is called a Trousseau sign, and this is where you take a blood pressure cuff, put it on the arm, and inflate it to a number greater than their systolic, and leave it there for about 3 minutes. If it's positive, you will notice the hand will draw in towards the body, and flexion will occur at the wrist, thumb, and MCP joints, but the fingers will remain extended. Another sign that you want to remember is called the Chavotsnik sign, and this is a nerve hyperexcitability of the facial nerve, specifically that cranial nerve 7. And to elicit this response, you're going to tap via the masseter muscle at the jaw angle, and the facial muscles on that same side that you tap will contract momentarily, so the lips will twitch. S is for sensation of tingling and numbness, known as paresthesia, and this can be felt in the fingers and the toes. Now, what can cause hypercalcemia, an increased blood level of calcium? Well, if you have an overactive parathyroid, where you're having too much parathyroid hormone in the body, because the parathyroid hormone is going to cause the release of calcium. And if we have too much, we're going to release way too much calcium in the blood. Next is increased vitamin D usage, because calcium likes to follow vitamin D, and there is a finite amount of vitamin D our bones will absorb. Having too much in our blood will then start leaching the calcium from the bones to balance out those blood levels. Also, using supplements with too much calcium in it. If a patient also has cancer that's spread to the bones, this can affect the calcium levels because it causes too much calcium to leak into the blood. And then finally, medications. Some main ones that you may remember are things like thiazide diuretics. And they can do this because they affect how the kidneys are absorbing calcium. Lithium is also another medication because lithium can affect the parathyroid hormone, which causes the body to have too much calcium. Now, what are the signs and symptoms that a patient has too much calcium? Signs that a patient has too much calcium in their blood are that they are going to be extremely weak. W is for weakness of the muscles. It'll be very profound. E is for ECG changes. And remember, they can have a shortened QT interval. A is for absent refluxes. And they can also have an altered mental status and abdominal distension from constipation. And then K is for kidney stone formation. So these patients are at risk for development of kidney stones. Now, let's talk about the electrolyte magnesium. So this electrolyte likes to hang out inside the cell, just like potassium does. And it has a function in the nerves and muscles, which plays a role with the sodium and potassium pump. So with this pump, you have ATP. And whenever magnesium binds with ATP, because ATP needs it in order to function, it's going to move 3 sodium ions out of the cell and 2 potassium ions into the cell. Therefore, we need a proper balance of magnesium in order for this function to occur. In addition, it plays a role with our vessels, maintaining our blood pressure, and how our muscles contract and relax. For magnesium to cause contraction, you have magnesium competing with calcium for that binding spot, which causes the muscles to contract instead of relax. So, think about it this way. If we didn't have enough magnesium to allow our muscles to relax, they will do the opposite, and instead your muscles are going to have spasms, they're going to cramp, and they're going to contract. A normal magnesium level is 1.5 to 2.5 milligrams per deciliter. As you can see, that range is very narrow. So let's talk about low levels of magnesium in the blood, also known as hypomagnesemia, and what can cause this. So, magnesium is mainly absorbed in our gut, specifically our small intestine. So if we have issues with our gut, as you're going to see with our causes, we can have issues with balancing our magnesium levels. And magnesium imbalances will more likely than not present with other electrolyte imbalances, like that of calcium and potassium. So a lot of times, if your calcium levels are low, your magnesium levels will also be low, and vice versa. One of the main causes of hypomagnesium is not consuming enough magnesium, or we have malabsorption disorders or of that of the small intestine. Another reason for low magnesium is if they are taking a PPI, a proton pump inhibitor, which can decrease the absorption of magnesium. Another significant cause for low magnesium is in patients who have alcoholism. Now let's talk about the signs and symptoms of low magnesium. So with this, you want to remember the word twitch, because everything in this patient is going to be really excited. It's going to be hyperactive. So T is for Trousseau's and Chavatsky's signs, and this is related to also having low calcium levels. W is for weakness. I is for increased deep tendon reflexes. Again, everything is going to be hyperactive. T is for torsade state points, and this is an abnormal heart rhythm that can lead to sudden cardiac death. It can be seen a lot of times in those patients with alcoholism. And then another T for this part is for tetany, those seizures and other ECG changes that can go with the calcium and potassium being decreased. C is for calcium and potassium levels low. They'll present together. And H is for hypertension, because magnesium helps with our blood pressure, and having a low amount can make those vessels more likely to lead to hypertension. Now let's look at the main causes of what can elevate the magnesium in the blood, known as hypermagnesemia. This condition is relatively rare and tends to happen whenever we're trying to correct a low magnesium. So if we're giving them too much magnesium. You want to monitor these patients that are in OB and labor and delivery if they're getting the magnesium replacement for preeclampsia, or if they're receiving magnesium replacement in an alcoholic patient to prevent them from having seizures. Also, impaired renal function can cause us to keep too much magnesium. Now, with hypermagnesemia, the signs and symptoms is everything in your body is going to be really slow and not hyperactive, lethargic. So let's remember the word lethargic. And typically this condition, you're only going to see it in severe cases. Mild cases may not present with any signs or symptoms. L is for lethargic, which may be profound. E is for ECG changes with prolonged PR and QT intervals, and maybe a wide QRS complex. T is for tendon reflexes absent or grossly diminished. H is for hypotension. A is for arrhythmias like bradycardia or heart blocks. R is for red and hot face. They're going to have flushing. G is for GI issues like nausea and vomiting. I is for impaired breathing due to skeletal muscle weakness. And C is for confusion. They can have neurological impairment, sometimes profound. Finally, let's talk about our last electrolyte, phosphate. So, phosphate plays a role in our teeth and bone building. It's absorbed in the gut, stored in the bones, and excreted in the kidneys. So, any issues with those structures, we're going to have an imbalance of phosphates. It's also regulated by the parathyroid gland because the parathyroid gland will tell the kidneys to inhibit the reabsorption. Also, vitamin D influences how we absorb phosphate. As you can see, there are some parallels between calcium and phosphate. A normal phosphate level is anywhere between 2.5 and 4.5 milligrams per deciliter. What causes low phosphate levels in the blood, also known as hypophosphatemia, is overusage of aluminum-based antacids. Too much of this will block the gut's absorption of phosphate. Also, starvation and refeeding syndrome can cause this. Refeeding syndrome occurs when a patient has experienced severe starvation, and then whenever we give them food, it can increase their blood sugar. But because they were under such extreme conditions, when the insulin is released in response to the increased blood sugar, it's going to need phosphate to change glucose into energy. So that is going to further deplete those phosphate levels, leading to the low blood levels of phosphate. Also, an overactive parathyroid can do this, because if we have too much parathyroid activity, we're going to majorly inhibit how the kidneys are reabsorbing phosphate. And then low vitamin D levels, because vitamin D plays a huge role in absorbing phosphate. Now let's look at the signs and symptoms of hypophosphatemia. And to help you remember the signs and symptoms, let's remember the word bone, because phosphate is huge with our bone health. So, B is for bone pain and fractures. O is for osteomalacia, and this is where you have softening of the bones. And whenever you have this, especially in children, it can affect their growth, making them shorter, and it can also result in bowing of the legs and how the bones are formed. N is for neurostatus changes. They can have irritability, confusion, and seizures. And then E is for erythrocyte destruction. Phosphates play a role with our red blood cells, which means we can have our red blood cells being destroyed, which then can lead to hemolytic anemia. Let's look at elevated phosphate levels in the blood, also known as hyperphosphatemia. Causes include overuse of phosphate-containing laxatives like Fleet's enema. So if a patient has renal failure, you definitely want to watch using those. Too much vitamin D, and also muscle damage, such as in rhabdomyolysis, which can damage your kidneys, and when your kidneys get damaged, we're not going to be able to excrete phosphates appropriately. And then finally, hypoparathyroidism, so an underactive parathyroid. The signs and symptoms of hyperphosphatemia can be similar to that in hypocalcemia. So patients with high phosphate levels may be experiencing convulsions. They may also have hyperactive reflexes, arrhythmias, spasms in their muscles, and they may also have itching. This is often found in patients that have renal failure. And they can have Trousseau's and Chavatot-Stick signs. Today we covered the basics of fluid and electrolyte balance and the causes and common signs and symptoms of imbalance. This is a foundational knowledge for every nurse. Remember, understanding these concepts is crucial for providing excellent patient care. Keep learning and stay curious. You're on your way to becoming an amazing nurse.